Next speaker, again, many of you are familiar with Dr. Lichter. And if you're not familiar with him already, what might strike you up front is not just his incredible intellect and his suave manner, but it's his just wonderful accent. I love his accent. He's from New Zealand, and so we'll get a great taste of that. In 1984, he was admitted to the Fellowship of the Royal Australasian College of Physicians. In 1989, he joined the faculty of the Department of Neurology here at UB. He's currently a clinical professor of neurology at UB, and he's involved in patient care, research, and is the director of the Movement Disorders Clinic at the VA Medical Center. So I'm sure many of you, due to that, have come across him. In 1995, he received a New York State Assembly citation. He's been listed among the best doctors in America since 1996 and is regularly mentioned in the local publication Buffalo Spree as among the best doctors in the area. One thing I'm sure he's not going to talk about today, but it's something that I would like to talk to him about sometime soon, is he's an avid chess fan. And I think chess would do wonders for keeping the Parkinson's mind active. And I know that there are many people out there that know chess or are very good at chess, and I think that it would be beneficial to maybe get some chess players together. So again, Dr. Lichter, we appreciate you coming. Thank you.
Well, thank you very much for that introduction, Chris. I have to say that a patient that I had dealt with over a number of years recently that I was following at the VA with Parkinson's finally got admitted to the palliative care unit there. He was in his mid-90s, and he was also quite a keen chess player. And so periodically I would meet up with him on his floor, and that's just what he wanted to do. He wanted to sit down and play some chess. So I'm sure there are some other fans out there who like cognitive exercise as well as physical exercise, and I certainly would recommend that for any of you who are oriented in that direction at all. So I've been asked to take Dr. Gattuso's information a step further. You've heard about some disease-modifying treatments for Parkinson's disease. And now we're going to talk, at least I'm going to provide some brief snapshots about currently available new treatments for Parkinson's disease. I'm going to talk mainly about medications here, but I've left myself hopefully a couple of minutes at the end to say one or two words about neurosurgical treatments, which you've already heard about from, I'll use the same words, Dr. Kelly, and also from Dr. Giroux, but just something in terms of perhaps some future modifications that you might be hearing about there as well. So one of the greatest areas of interest right now is how do we improve the efficacy of levodopa, seeing this is the most potent and effective medication that we have for the motor symptoms of Parkinson's disease. As you all, I'm sure, know about and have heard about already this morning, despite its great efficacy for the treatment of motor symptoms, over time, unfortunately, you start to develop motor fluctuations, so wearing off effects where the medication doesn't last as long as it should, sometimes sudden off periods, and also coming along with that, the development of drug-induced dyskinesias. It's also been shown previously that if you can maintain stable plasma levels of levodopa, and that's been done with levodopa infusions, for example, that you can overcome not only the motor fluctuations but also the dyskinesias. So people have been looking for some time now at various different techniques that we may be able to use to have a more effective, stable delivery of levodopa rather than the oral medications that we have now. So I'm going to start off with some therapies, one available right now, Rytari, and a couple that you will be hearing about in the very near future also. So some of you may already be on Rytari. This is a medication which contains beads within the capsule, some of which dissolve fairly quickly and result in a peak dose concentration within about an hour of taking the medication, and some of which are designed to dissolve at a more slow rate and then provide a more sustained level of levodopa in the system to try to alleviate the wearing off symptoms. And in fact, in earlier controlled trials, this is what was shown. People in the more advanced stages that compared with regular release carbidopa, levodopa, where patients in those trials were taking on average 5 doses a day. With Rytari, that could be reduced on average to about 3.5 doses per day. and this resulted in an improvement in off time of around a couple of hours on average, and also an improvement in on time without troublesome dyskinesias, which we all look for, which were also close to 2 hours. So this we now have, as I mentioned, I'm sure some of you may already have been honored or have at least discussed this possibility with your own doctor. What we have found is that it's still, unfortunately, challenging to use this drug in those more advanced patients who have very short duration wearing off symptoms and who have a lot of dyskinesias associated with that. So just that kind of patient group that we're really the most interested in helping turns out, not surprising because we've had this experience with other drugs in the past too, to be the most challenging group of patients to treat even with Rytary. But Rytary is not the end of the road here. Another formulation for more continuous delivery of levodopa, which has been available in Europe for quite a number of years, is now available here in the United States. And this is Duopa, the levodopa intestinal gel. And as you can see from this schematic, it's delivered directly into the small intestine where levodopa is absorbed by a portable infusion pump, which can be kept going for up to 16 hours a day. So you'll see that it's delivered through a percutaneous gastrostomy into the stomach, but then there's a tube which is threaded down into the first part of the small bowel to the active site of levodopa absorption. So this has been shown to be effective for reducing fluctuations in dyskinesias, particularly in more advanced patients, and it's been used overseas and is really designed to be used in this country too, predominantly for those more advanced patients who normally one might consider for deep brain stimulation, but for who one reason or another, sometimes for reasons of cognition and so forth, may not be candidates for DBS. They will very often be candidates for this form of therapy. So it has pros and cons. As I mentioned, it can result in significant improvements in off time and an on time without troublesome dyskinesias associated with improvement in quality of life and in activities of daily living. But there are some complications, some adverse effects of using this particular device. And as you can see here, some of those procedural and device adverse effects and events in a large number of patients who have received this were shown to occur in up to almost 3/4 of patients. So some of these were not too severe, but some of them were more severe. There were complications of device insertion in about 40%, abdominal pain in about 36%. A few patients even developed peritonitis, which you don't want to have. Post-operative wound infections also in about a quarter of patients. In addition, you have to recognize that this device is there permanently. It requires continuous maintenance and programming. The tube connected to the stomach requires constant monitoring for infections. So there are some issues with the use of this device. Nevertheless, for patients who are very incapacitated by their Parkinson's, who can't be given the option of deep brain stimulation, this is a methodology which we have and which may restore a more useful quality of life for those groups of patients. Now, what we'll see in the future are other options to Rytary, and one of these is the so-called accordion pill of levodopa carbidopa, which is under development, and this is a more gastric retentive form of levodopa. It requires both carbidopa and levodopa, again in immediate and controlled release formats like Rytary, as opposed to Rytary, where we saw maximal benefit of the drug often for maybe 5 hours, 6 hours in the most advantageous situations. This drug promises to deliver stable levels of levodopa for about 8 hours. And you can see this from the graph below, where you'll see the response to regular release carbidopa levodopa in terms of the peaks and troughs and plasma levels when that drug is delivered every 4 hours. And what you see with the accordion pill dosed every 8 hours. And you can see there's a much more continuous plasma level here, avoiding the peaks, which may be related with peak dose dyskinesias, and avoiding the troughs, where you're more likely to develop off-period symptoms. And in fact, that's what has been shown so far in the clinical trials. If you just focus on the right-hand groups of bars in both of these bottom panels, you'll see this a significant reduction in off time in the pink bar compared with the regular release levodopa on the right of the left-hand panel, and associated with that a reduced number of periods of on time with troublesome dyskinesias with this drug. So far this looks very promising, and you'll definitely be hearing more about this particular pill in the future. The other thing that I'm sure some of you have heard about is inhaled levodopa. So this is an inhalational form of levodopa. It comes in a capsule which has dry powder in the capsule. And when this is used, it's been shown that the concentrations of levodopa in the bloodstream rise to therapeutic levels in about 10 minutes. So that's very much what you look for and what you see currently with the apomorphine injection. In a recent trial at a dose of 50 milligrams used twice a day, this resulted in about 1.6-hour reduction in daily off time, which was about a third reduction in off time compared with these patients' baseline state. As I mentioned, the main benefit, though, is the very rapid onset of improvement in these off symptoms. So it's rescue therapy like the kind of rescue treatment we see with apokine, but obviously in a more patient-friendly method of administration. So a phase 3 study with this device is being completed, and the goal for the drug company is to have a new drug application for this device in the first quarter of next year. And there are other novel forms of levodopa delivery also in development. One is called Xenoport, which is actually a levodopa prodrug, but once this is absorbed, it's rapidly converted into levodopa in the GI tract. It uses a naturally occurring high-capacity nutrient transport in the GI tract, and again, it's designed to result in more efficient absorption. There's also another form of levodopa called deuterated levodopa. Normally, dopamine in the brain is broken down by two different enzyme systems, which we often block when patients have wearing-off effects. This deuterated form of levodopa is more resistant to enzymatic breakdown, so again, it promises to prolong the action of levodopa in the brain. And then finally, there are a couple of new products under development by this firm called Neuroderm. This is actually a liquid formulation of carbidopa-levodopa, which will be available for delivery either by pump, which will be worn on a little belt, or by skin patches. So the skin patch is shown in the lower right-hand panel here. It's about the size of a credit card. It has a little reservoir containing the liquid levodopa. And in addition, there are a series of fine microneedles, which are painless, which pump the drug under the skin and then into the bloodstream. And so again, it's the same thing. This is designed for more continuous delivery of levodopa to avoid these wearing-off effects and associated dyskinesias. And both of these forms of delivery are designed for patients with moderate to severe Parkinson's disease. So now, an alternative to levodopa, as you know, is apomorphine. We've already talked about the subcutaneous form of apomorphine, apokine. Dr. Gattuso and I were just talking a few minutes ago about how many of our patients we have on apokine, and it's actually a very small number. And that's because patients generally don't like the idea of injecting themselves with a device like an insulin injector. Even though it can be very effective, there are also some side effects of apokine administered that way. So under development now is a sublingual form of apomorphine, which will be a thin film which the patient places under their tongue, which dissolves over the course of a few minutes. So initial double-blind placebo-controlled trials have already been conducted. There's an open-label 6-month safety and tolerability study which is now underway. And this is going to be very similar in the kind of patients that it's going to be targeted for use for as the powder form of inhaled levodopa, and that the onset of action of this drug comes on as early as 10 minutes after dosing. And it lasts for about 90 minutes. The treatment seems to be safe and well tolerated, and there don't seem to be the same kind of side effects that we've grown used to seeing with subcutaneous forms of apokine. So we have to be very careful there about postural hypotension, about nausea, sometimes about local irritation. There don't seem to be any of those kinds of side effects with this delivery of apomorphine. So again, this is going to be an alternative to inhaled levodopa, and hopefully both of those products should be on the horizon fairly soon. Now I want to switch gears a little bit to talk about glutamate receptor antagonists, and particularly amantadine. Again, some of you may have been on amantadine in the past. This was a medication that years ago we used to use for the primary motor symptoms of Parkinson's disease. Nowadays we tend to use it more for drug-induced, levodopa in particular induced dyskinesias, because there's a particular mechanism of action. It's a glutamate antagonist. That's an excitatory neurotransmitter, and we block the action of that excitatory neurotransmitter with amantadine. So there's an extended release form of amantadine, which is actually due, if all predictions are correct, to be released as early as next month. And this, again, in trials has been shown to reduce dyskinesia significantly. As opposed to regular release amantadine, it's designed to be given once a day at nighttime, with the peak dose of this drug then occurring about 12 to 14 hours later during the time of the day when you'd expect levodopa dyskinesia to start to come on. As opposed to regular release amantadine, it doesn't seem to have any adverse effect on quality of sleep. Now, the side effects are the same. It's the same drug, so we always advise patients who are going on amantadine that in addition to rather kind of mild side effects like dryness of the mouth and constipation, there are some more serious potential side effects of amantadine, effects on cognition, particularly if you've got memory problems to start with, and hallucinations. In older patients, those who have memory problems and other cognitive problems to start with, we sometimes have to be very careful about using this drug. So the same applies to this extended release format. But nevertheless, it's an option to regular amantadine, which may have some advantages, and as I say, it's going to be available very shortly. Also under development is a combination of amantadine with topiramate. So topiramate's an interesting drug. Topamax, some of you I'm sure have heard of it. It's used for other conditions like certain seizure disorders and migraine. It's also used for other movement disorders like essential type tremor, and other movement disorders used for as tic disorders, where they're involuntary abrupt little movements, often seen in children but also in some adults. And in at least animal studies, it's been shown that topiramate can be effective for drug-induced dyskinesias. So the thought has been that if you combine this drug with amantadine, maybe you'll have a better effect on drug-induced dyskinesias. And it's important that the drug companies continue to look for medications for dyskinesias, because although many of you may have experienced dyskinesias in a relatively mild form, which are not troublesome. As you've seen from the descriptions of the clinical trials, what we like to avoid is on time with troublesome dyskinesias, because eventually dyskinesias do get to be troublesome for some patients. And if you can't reduce the levodopa dose, and if you can't use amantadine because of side effects, the only option is deep brain stimulation, and that is not available as an option for all of our patients. So this is one drug combination which hopefully may help us a little bit further down that road to finding a more effective drug for dyskinesias. Now I want to switch gears a little bit and talk about some new and pipeline drugs for some of the non-motor symptoms of Parkinson's disease, which, as many of you know, are at least as bothersome and sometimes more bothersome than some of the motor symptoms. Northera, or droxidopa, is a new medication. Some of you may already be on this medication, but it's an alternative to some of the older medications we had, such as fludrocortisone and midodrine for symptomatic orthostatic hypotension. That is where your blood pressure falls by 20 or more millimeters of mercury when you stand up, which can result not only in dizziness but weakness, sometimes even blackouts. So this drug has been available overseas, particularly in Japan, for a long time, but only recently now available in the United States. So you, like other drugs, you start off in a low dose. It's generally used 3 times a day, and you work upwards until you get adequate control of symptoms, monitoring for any worsening of supine, that is in a lying position, hypertension. So all of these drugs used for orthostatic hypotension have the potential in a patient is sitting or lying down to bring the blood pressure up to too high a level, so we have to monitor for that. It's also recommended with this drug that the patient sleep with the head and the body elevated, and we do recommend that for other patients with orthostatic hypotension too, because that can improve, again, control of daytime orthostatic symptoms even without drug therapy. Pimavanserin, or Nuplazid, again, some of you may have heard of this drug, which was approved by the FDA just a couple of weeks ago. This is the first drug ever which has been marketed specifically for psychosis in Parkinson's disease patients. So previously we did have antipsychotic drugs which had been developed for schizophrenia and other psychoses, which had been applied to the use of Parkinson's disease psychosis, but which had a number of problems associated with them. And the first is that by far and away the majority of those drugs have the distinct potential and effect in the vast majority of cases of worsening motor symptoms of Parkinson's. And there are only two drugs of that class, which are called dopamine receptor antagonists or blockers, which can be safely used in Parkinson's disease. One is a drug called clozapine, which unfortunately can produce severe lowering of the white count, or a condition called agranulocytosis, which affects all the formed blood cells, which can be a lethal condition. So you have to monitor the patients on clozapine with blood counts every week. And that it's also an expensive drug. And the only other alternative is a drug called Seroquel, which is only marginally effective, maybe mildly effective, but not nearly as effective as we would like it to be. So this is the first drug, which is a non-dopamine receptor blocker developed for Parkinson's psychosis, shown to be effective in clinical trials, shown also to reduce a number of other, to improve a number of other aspects of the Parkinsonian condition, including nighttime sleep, wakefulness, and during the day, and also reducing caregiver burden. And it does seem to be safe and well tolerated. So I'm spending a little time emphasizing this because although many of you, hopefully the vast majority of you, haven't had any troubles with hallucinations or delusions or other aspects of psychosis, if you look across the long range of Parkinson's throughout their lifespan, there's about a 40% incidence of psychosis eventually. So when you get to be older, when you've had the Parkinson's disease for a long time, when you start to develop cognitive problems, unfortunately psychosis does tend to creep into the clinical picture. And it can be a source of incredible caregiver burden, and it's probably the number one reason that patients with Parkinson's disease are eventually institutionalized. So it's now nice that we have this option available. So I wasn't going to say anything about medical marijuana, but I knew there were going to be some questions about medical marijuana, so I thought I should say something about it. And the first thing to say is that it's actually not a new drug for Parkinson's disease. This was used in the 19th century as an alcoholic tincture, cannabis indica, to treat Parkinsonism. We know that there are several brain cannabinoid receptors. In fact, the densest areas in which these receptors are found in the brain are in the basal ganglia, the regions which are involved by Parkinson's disease. And we also know from a number of recent papers, and certainly from quite a large number of personal anecdotes, some of which have been called into the National Parkinson's Foundation hotline, that some Parkinson's patients have experienced improvement in some of their symptoms, some of their motor symptoms in some cases, but also some non-motor symptoms such as mood and quality of life and sleep with marijuana. These reports, however, have not been controlled, and including some of the studies which have done with medical marijuana have not been double-blind, placebo-controlled studies. In other words, they lack scientific rigor, and for that reason, a recent guideline development subcommittee of the American Academy of Neurology, looking at the evidence base for medical marijuana, determined that at this point in time, there's insufficient robust scientific evidence that marijuana is helpful for Parkinson's disease-related tremor or levodopa-induced dyskinesias, and the head of the National Institute of Drug Abuse and Addictions, Dr. Noro Volko, also has recently emphasized the adverse health effects of marijuana in some cases, which you'll see listed here. A small percentage of patients may become addicted. With heavy use, you can even see psychosis or hallucinations. It certainly can impair, not improve, but it can impair aspects of motor functioning and cognition. If you've smoked marijuana, it actually doubles the likelihood you're going to have a motor vehicle accident. And the strongest support does not seem to be in Parkinson's disease. It's in other disorders like glaucoma, conditions which can cause severe nausea, certain wasting syndromes like AIDS, conditions where there's chronic pain, and certainly in multiple sclerosis, where there may be spasms and pain for other reasons, and epilepsy, there are good indications for medical marijuana. We don't have the strength, that robust strength of that evidence in Parkinson's disease yet, but it is now legal in New York State. It can be prescribed for Parkinson's patients. There are associated conditions for which it's recommended to be prescribed for Parkinson's patients, and again, that is if you have a lot of weight loss with Parkinson's, if you have severe nausea, if you have a lot of pain. Now, Patients with Parkinson's disease may have pain for other reasons. May have back or neck problems, for example. That would not be a reason for its use, but it's much rarer to have what we call central pain as a symptom in Parkinson's disease, but it can be prescribed for that. And also if you happen to have a lot of spasms, which is also somewhat unusual, but like in multiple sclerosis patients, for example, those are the kind of categories of Parkinson for patients for which, at least in New York State, this drug is going to be recommended. Its use is restricted to licensed providers, but it is available. So this just summarizes that although we don't have the evidence base for its use, there is mounting evidence that it may be useful. We don't know precisely for which Parkinson patients, in terms of the motor or non-motor symptoms, is going to turn out to be the most effective. We hope that we'll be able to gather more evidence to support guidelines for use of medical marijuana in Parkinson's in the future. I would say along those lines that this is still a Schedule I drug. That is to say that the FDA considers that it has no approved medical use and or it has abuse liability. So what many people have emphasized is that one of the most important things that happen in the future is that it is changed from a Schedule I to a Schedule IV or Schedule V drug. And that change would, I think, definitely improve access to medical marijuana, not just for Parkinson's, but for other neurological disorders. And it will also facilitate the kind of controlled clinical trials that we really need to move this field forward. I'm not going to say anything about nilotinib. This is a fascinating drug. We've already heard about this from Dr. Gattuso. If you have more questions about that drug, certainly we can cover it in the discussion in a minute. But I want to conclude just by saying a few words about surgery. Now, you've already heard about surgery from Dr. Kelly. I just want to emphasize that there are a couple of interesting points here. Now, one question from the audience already was related to MRI-guided focused high-intensity ultrasound. I knew there was going to be a question on that, so I prepared one slide on it. So it has some pros, but it also has a lot of cons. The pro is that it's non-invasive. No wires, no pacemakers, no follow-up visits for reprogramming necessary. It is an option for some patients who have medical contraindications then to deep brain stimulation. There are, however, quite a large list of cons. It's not FDA approved. It's risks, because what you're doing is you're thermocoagulating an area of the brain, and its risk is very similar to previous destructive surgical procedures that were used before we had DBS, like pallidotomy or thalamotomy or subthalamotomy. Also, even though it's MRI guided, you can't precisely localize a lesion like you can with DBS, because you can't use microelectrode recording or physiological mapping to really define very precisely within a millimeter or two where you want this lesion to go. You also can't use it bilaterally, and that was a problem when you were considering bilateral pallidotomies in the past, because if you did bilateral pallidotomies, and also the risk of this procedure bilaterally, is you can have significant adverse side effects. You can have severe side effects in bulbar functionings, that is speech and swallowing. Also cognitive problems can emerge. So this is not used bilaterally. It can be used for unilateral tremor or unilateral dyskinesias. And clearly if you've got evolving symptoms of Parkinson's disease, it's ultimately going to become bilateral. This is not probably going to be the option that you want. In addition, as I mentioned, you can't reprogram it. If you have a less than optimal result of this procedure, like the previous surgeries, there's no way of going back and reversing it, and you can't fine-tune it by reprogramming it. So that is ultrasound. So a couple of issues just related to DBS, which you've already heard about, and Dr. Giroux kind of commented on this very briefly in her discussion, is the question of when to do DBS. So there was a study which came out, I think it was around 2013, and this was a study called the Early STIM study, which was a study done predominantly on French and German patients who tended to be younger, at a younger age. Some were around 50 years of age. They had had their motor fluctuations and dyskinesias for only about 3 years. And what they did in this study, which is really quite a change compared to what had happened before, where we used to reserve DBS for much more advanced patients, was that they offered DBS to this group of patients as opposed to best medical treatment. And I think everybody was really surprised by the results of this early study, because it definitely showed that those patients who were just kind of in a really kind of intermediate phase, they were not advanced yet, there was a definite advantage of DBS surgery for that group of patients over best medical therapy alone. That did come as a big surprise, I think, to a lot of people. The issue is that it's still surgery, and as you heard from Dr. Kelly, there are definite, small but definite risks, some of which can be serious risks of DBS. So you really have to weigh that in the balance. But I think what this study has definitely done is it's shifted the way we think about DBS a little bit. I think it's moved the pendulum a little bit more towards slightly earlier DBS in some patients rather than just restricting it to patients with very advanced disease. The other issue, which has not completely gone away, is the site of stimulation for DBS. So it started off with globus pallidus stimulation, and then it moved to subthalamic nuclear stimulation, which is all we do in Buffalo. It's by far and away the preferred site of DBS stimulation now in centers across this country. Both are still viable options. However, it is interesting, if you look at what people have been publishing in recent years, the pendulum may be swinging back a little bit towards GPI stimulation as opposed to subthalamic nuclear stimulation for certain groups of patients. So one interesting observation is that with subthalamic nuclear stimulation, as many of you know, one of the things that allows you to do is fairly dramatically reduce the dose of your dopaminergic medications after the surgery. And that dose reduction is not quite so dramatic. You can't do it to quite the same degree after GPI stimulation. However, what's been shown in at least one study is that the ability to manipulate the medications optimally seems to be a little bit easier. There seems to be more flexibility in being able to do that with GPI as opposed to STN stimulation. So that's one thing. The other thing is that in patients who present initially with resting tremor, which is actually the sizable majority of Parkinson patients, one study showed that in patients who had been given GPI as opposed to STN stimulation, walking seemed to improve a little bit more in those in the GPI group. This is only one study, but it's something also to keep in mind. And we still are of the opinion, and most people agree, that GPI, which is used for dystonia, where you have abnormal muscle contractions and posturing, which may be a disease all unto itself, but which we see in some muscle groups in Parkinson patients, particularly earlier onset Parkinson patients, where it may be seen particularly in the feet and the toes. If you have a lot of dystonia associated with your Parkinson's disease, the GPI is still the preferred site. So this issue has not completely gone away. I don't think it's the end of the argument, and it may be that in the future we're going to see GPI recommended a little bit more for certain patient subgroups, perhaps not just those with more prominent dystonia. And I want to finish up by just saying a few words about some advances in DBS technology. So what we're hearing about now is that being under development, there are different DBS leads. There are leads with more contact points, capable of customizing the current, steering the current, shaping the current better. There are a number of companies which are involved in this effort. One is actually Medtronic, which is one of the sponsors for this meeting today. There are also novel pulse sequences being developed, which could potentially reprogram the battery a little bit like the way you might update the app on a cell phone. And there's also this technique or a concept now of closed-loop DBS stimulation. That is where the stimulator monitors your brain waves, if you like, signals coming from the cortex in real time constantly, and the stimulator is designed to respond only to certain kinds of signals coming from the brain. And there may be signals which start to occur when you move into an off period, particularly when you go into off-period freezing, for example. The stimulator will sense that. It will kick in at that time, deliver the appropriate current, customized, steered, shaped the right way, just for those kind of periods when you're at your worst from a motor standpoint. And then it may actually switch itself off at other times. So it's continuously monitoring, delivering current, remonitoring, and deciding whether or not you need the current again at a future time. So I think you are probably in the future going to see some of these closed-loop devices become available. So I think at that point I'll finish. Thank you.